I'm going to talk about distal radius fractures, 5 keys to surgical success. And as we all know, there's all kinds of nuances with respect to fixing these fractures. It's not an easy thing to do, but I think that if you understand just a few principles, things can be a lot easier. So the first thing is to recognize the challenge. And, I work with residents and fellows, and they come to me and they say, hey, I have this great case and it's going to be a chip shot. And you look at the x-ray and you're like, that's not going to be a chip shot. Right. So you sort of recognize these very challenging x-rays, like, for example, this one. Right. So this might look like a chip shot, but it's not. That volar marginal fragment is a real bad player. And if you don't recognize that that exists, as part of your sort of preoperative surgical planning and make sure that you have the tools that you need to fix that, you end up with a disastrous outcome as the risk goes volar and proximal. And we learned this from Malone, and there's been multiple studies looking at the loads across the distal radius. And we know that that volar marginal fragment is like the anterior labrum in the shoulder, right? If it's not intact, everything kind of goes forward. And so you have to have some sort of fracture specific fixation for these injuries. And I like to use a little hook plate. This is another bad player. So this is a very, very distal radius fracture. And if you really scrutinize this x-ray, you can see that this articular surface has basically been sort of shaved off distally. You have part of the articular surface still intact. So you're going to have to fight that. This is a young person with good bone that, flew off his motorcycle. And so these very distal fractures can be incredibly challenging. And you want to make sure that, again, you're prepared to deal with all of these problems, which is, fracture lines past where you can place your plate. And we'll talk a little bit more about this, but the watershed line is the spot that you don't want to violate, because if you do, you end up with flexor tendon problems. And so again, you have to be, ready to deal with this problem on both the radial and ulnar side of the wrist. And so, you sort of capture not just the bony components, but also the ligaments. This is almost like a ligamentous avulsion. And, as Jason and I were just talking about, you have to have these adjunct treatments like the dorsal spanning plate. So after you've done the best that you can to try to stabilize these fractures, if it's still not stable, then you have to do something else, because you have to have a stable fracture to be able to allow these people to use their hand. And this particular patient was a polytrauma. And so, pelvis fracture and femur fracture. And so this person needs to be able to use his hand to transfer. So number one is understand your challenge. Some of them are straightforward, but when you deal with these more complex injuries, it's good to be able to recognize that just out of the gate. Next is visualization. You have to be able to see what you're doing, and exposure is so key. And when I get called in the room to help, it's usually because the exposure isn't good enough to be able to see what you're doing and what your fracture fragments are. Everything is like a big bloody mess. It looks like a bunch of, ground up hamburger meat, and you can't see where anything is. And it's because the visualization isn't good. And so I have basically transitioned entirely to the extended FCR approach. And we have all changed the way that we do things over the course of time. And when I started, I did the volar approach of Henry. That's what I did in fellowship. And then I learned about the extended FCR approach, and I dabbled in it a little bit. And then I just have completely converted, because it's really the best way to visualize this fracture. And of course, this is something that is promoted by George Orbe, who has really described this. But it's really a distal extent of the volar approach of Henry, and it's like the approach that you use for scaphoid fractures. So this is not something that is unusual territory for us, and it really gives you really great visualization. So how long is the incision? Well, as long as you need, right? So if it extends into the shaft, you make it longer. If it's more distal, then you don't have to make it so long, but you do have to cross the wrist flexion crease. When you're doing this, you have to know your anatomy. So this is a case that I just did this week, I think on Tuesday, with the third-year resident, who is fantastic. He's like functioning at the level of a fellow. And we get in there, and this is what we find, like the median nerve is right there, and that's the palmar cutaneous. So you have to be vigilant, and you have to train your eyeballs to see all of these different, anatomy structures. And, his eyeballs were about this big when we, cut down right on the median nerve. But sometimes the anatomy is shifted a little bit. This particular case, he's a prisoner. He presents delayed. Things are funny in there. And so again, you have to be really vigilant and know your anatomy. Now, with respect to exposure, so this is a very, very ulnar fragment. And can you get there with the extended FCR approach, or do you need to make an incision, right over that fracture? And this is what the visualization that you can get with the extended FCR approach. You basically can see that volar lunate fragment very well. You can get perfect exposure. I mean, you can get a perfect reduction. You can see that ulnar corner and really get this well reduced and reestablish the joint of this 19-year-old young girl who ultimately has really good outcome. So what is the extended FCR technique? And this is all out there in the literature. There's multiple papers written on it. I still read those papers. I think that there's a lot of good sort of pearls in there that you miss the first 10 times you read the paper. But you have to really release the FCR. It's the tendon sheath, and the FCR attaches to the trapezium. That's another concept that I think we don't totally get, is that the FCR attaches to bone. And, we think about the FCR attaching distally to the metacarpals, but there is an insertion on the trapezium, and it's there every time. And so you really have to release that. You have to release that distal flexor retinacular leaf. There's a superficial and a deep portion. In order to be able to mobilize the FCR. And then that's the attachment on the trapezium. And you really just go right past the trapezium. There's nothing there that you're going to hurt. You're not going to cut any nerves. I mean, it's totally safe. And then you get this beautiful exposure. The next thing you have to do is release the radial side of the wrist. And basically how I think about this is I'm releasing all the tethers on the radial styloid. And so you basically follow the line from the flexor retinaculum and along the brachioradialis and elevate that entire soft tissue to be able to visualize the radial structures. And you want to get over to the first dorsal extensor compartment. And I do it the same way every time, just like a scope. So first I release the first dorsal extensor compartment. I'm very careful with the radial artery. I've had many of those cut by, lots of well-meaning surgeons, and you just fix it, but it's better if you don't cut it. And it's, it's in the superficial tissues. It's just superficial to the first dorsal extensor compartment. So you're just careful with that and you protect it. You release the first dorsal extensor compartment, and then you step cut the brachioradialis. Now, with respect to how distal you release your pronator quadratus, your landmark is the volar rim of the lunate fossa. And that is palpable in almost every single distal radius case. The most comminuted, blasted, motorcycle, fall off a 30-foot roof, they're palpable. And so that's, how I typically do it. If you can't palpate it because it's too smashed, then I basically release the pronator from proximal to distal instead of distal to proximal. And so let's go through the steps. So this is that distal extent. That's the radial border, and that's brachioradialis. And brachioradialis I find is easier to find proximal than distal. If you're looking for it at the level of the radial styloid, oftentimes you end up in the first dorsal extensor compartment, which isn't a bad thing, but you just have to make sure that you're step cutting the right structure. So this is elevation of that tissue over on the radial side, and we'll do this during the demo today as well. Release the first dorsal extensor compartment. That's APL, EPB. So those are your first dorsal extensor compartment tendons. You get them out of the way. And then you step cut your brachioradialis, and now you're ready to elevate your pronator quadratus. The watershed line, the volar rim of the lunate fossa, is sort of that distal extent of the watershed line. You don't want to place your plate any more distal than that, because then you get in the trouble. You have to elevate that area sharply. So the transitional fibrous zone is fibrous and it's attached to bone. You have to elevate it with a knife. Otherwise, you basically shred it, and then you can't see your distal fracture fragment, especially if your fracture is very distal. If your fracture is, sort of metaphyseal diaphyseal junction, those are a lot easier to fix, but we don't get very many of those. Most of ours are very high energy injuries. And so elevate your transitional fiber zone, then elevate your pronator, and then you pronate the proximal fragment. Now, what is the point of pronating the proximal fragment? It seems a little aggressive. That's what I thought initially. Well, you can actually release all of the dorsal tethers on your distal fragment. What does that mean? Well, when you have these fractures, there's hematoma and healing. In New Mexico, we basically fix no fracture till it's healed. Everybody presents delayed. And so you have to release that dorsal tether, or you can't get your volar tilt. And so you pronate the proximal fragment, you can rearrange all the pieces in there, and then restore your articular surface. So this is one of the cases that, again, this is a relatively recent case. So this guy is, again, he presents delayed. This is a very bad distal radius fracture. Look at all this callus. Like there's callus and irregular sort of bony surfaces on the volar wrist. So if you see this on the volar side, imagine what's going on the dorsal side. So you have to get back there to be able to release the tether on your distal fragment to get your volar tilt. And so you do all the things that we do as orthopedic surgeons, right? You get rid of the callus, you try to mobilize the fracture, it unsticks, it sounds like Velcro when it finally goes, and you're like, yes, it's going to release, right? It's going to be a good day. And then this is what you find behind the wrist. This is periosteum. So this is bone. This is periosteum, and all of this mess back here is callus, and it's stuck to your distal fragment. And so if you don't release this, you can't get your volar tilt. And sometimes you can't translate that distal fragment volar because it's shifted dorsal. And then when you divide it, it looks like this. So that, look at how thick that is. Like that stuff is super stout. And so divide it, and then you can put that distal piece pretty much anywhere you want. So, stick to your guns and extended FCR and do it the same way every time. It becomes very easy to do. And it's just, once you release all the things and reduce your fracture, then it's just a sawbones exercise. Anatomical reduction is very important. It doesn't matter what system you use, all of these plates are anatomical. And so if you don't get your fracture fragments back where they go, then your plate's not going to fit and your screws are going to be in the wrong spot. And so, even these very complex distal radius fractures with all these fragments, you can get, with volar marginal fragments, like recognize all these things, you can get them all back home. You put a bunch of K-wires in there. I like to start with the central column, basically the DRUJ portion, and then work from there radially. And as I reduce and mobilize, and my resident calls this the radial styloid squash, right? Because oftentimes it's trying to like fly off into the breeze, so you kind of push it back where it goes, and then even those very bad fractures, you can end up with a very, very good outcome. This is extremely helpful. So this is a little reduction maneuver where you put your thumb on the plate and your index finger on the dorsal distal fragment. And basically you give it a little push and you get your volar tilt. And this is, again, you have all these FLAIR scan opportunities. So this is a case that was relatively recent. And this is her dorsal tilt, right? So this is a young psychologist, and she's got some eating disorder stuff. So she had a low energy injury and broke her wrist. But she's got dorsal tilt here, probably 15, 20 degrees. And this is the maneuver. So you do that thumb on the shaft and then index finger on that dorsal distal fragment, and you give it that little torque, and it gives you perfect volar tilt. So it's a good thing to be able to know how to do. Optimal plate placement. You cannot violate the watershed line. It leads to disastrous results. And so you have to be able, again, to manage all of these distal fragments as whatever tools you use to be able to capture them. And you cannot go distal. You have to get your screws subchondral, because that's where the good bone is. The subchondral bone is stout. It holds load. If you put your K-wires or your screws in the cancellous bone, then you have settling. And so you don't hold your length. So 2 millimeters proximal to the watershed line with your plate, 2 millimeters proximal to the subchondral bone with your K-wires. And then make sure that all your screws are the right length, because if they're sticking out, they're going to cause trouble and you're going to get tendon ruptures. This is a paper that we published out of our institution way back in early 2000, talking about the plating system that we were using and how there were 2 specific screws that if they perforate the dorsal cortex, you would end up with EPL ruptures. So, in terms of fixation, so again, you can't violate the watershed line, and you have to recognize these sort of bad players. And if you miss it, this is what you end up with. So this is an example of a volar marginal fragment that went, there was an attempt at fixation, but it wasn't adequate, and you end up with this problem. And what happens to the tendons? This is what happens to the tendons. So this is FPL and FDP index. They're completely ruptured and scarred. And what I found is that sometimes the rupture is so scarred that the 2 ends can still be sewn back together again because it doesn't retract. So this is like a fretting and irritation and scarring of the tendon, and eventually it gives. This is one example of what you can find in there. This is another example. So this woman didn't actually have rupture of her FPL, but she had fretting. So you can see this is a totally tortured tendon. FDP index was fine. FPL was totally ruptured, and she had crepitus and all of the things. So we took her plate out and she did fine. And lastly, going back to this, you got to get your screws subchondral. You got to have the right plate width, and you have to have the correct length screws, because the tendency, my understanding is, across the United States, we tend to use narrow plates. So everybody uses the short and narrow 3-hole plate. And if you have a big guy, that probably is not the right plate for him, and you won't be able to span the entire subchondral surface. And this is really what you want. You want your plate to span the width of the distal radius. You can see that these K-wires are basically on either border of the distal radius on the extended tangential view. And then you want your screws to be within a couple millimeters of the dorsal cortex, so that you support that well. And we looked at this in the lab. We looked at plate width, we looked at plate position, and if you get that in the right spot, you have much better hold of your distal fracture. And this was all a cadaveric study. And so subchondral screw placement. And then this was looking at wide versus narrow plates. And again, you want to make sure that you have the correct width and the correct length screws. And that is all.